Any last minute questions?
No, I will try to be simple, to get simple in my slides, so we have time for final questions or
Yeah, perfect.
analyze on time.
Um, a lot of the people on the webinar come from lots of different places, lots of different practice settings. And so it's good to make sure we cover the foundations first before we get into more advanced topics. So thank you for that. Okay, can you see my slides?
Yep.
Yeah. Yeah.
Okay, so we have 3 more minutes. We'll wait for the 3 minutes. Dr. Lorenzo, how are you this morning?
I'm well, Dr. Crawford. Dr. Crawford, there was a very brief period there where we couldn't hear you when you went
Oh,
to the live stream. I just want to make sure
oh,
that's
okay. But if I share, let's see, if I share, let me see if I share my screen for the slides. Can you hear me now?
yes, now we can hear
Okay,
you.
okay. That's all we need then.
Okay, thanks.
Thank you. The live stream is happening now, but if you start the live stream and then go back to Zoom without muting the live stream on YouTube, then you start to get feedback. So we've had to figure that out over time. But so now if our waiting room fills up, people will be directed to the live stream, which is fun.
Fine.
Okay, 2 minutes. Dr. Comiskey, did you have any questions? Your old hat as my partner in crime here.
Nope, ready for another session. I'm good. Thank you.
Good. I love it. It's so fun to see people from surgery, emergency medicine, anesthesia, critical care,
This is
Kenya,
what we were hoping for.
Ethiopia.
That was the
Yeah,
whole
this is
point.
great. I love it. It makes me happy. And then I look at the waiting room and I see, friends from all over the world too. It's really quite fun.
Multi-professional party.
Yeah, that's how it should be.
Yeah, you guys have done such a good job of creating this whole series. It's awesome.
It's fun. Yeah. Next month we have our first of 2 sessions on frequently asked questions. So we actually go back through all of the registrations from the first 5 sessions, and people have an opportunity to type in their questions at that point. And so we pull all of those, and the ones we think are really important from the sessions that everyone should know, we go through those, and then some of the ones that we didn't get to because we run out of time because we're having so much fun every session, then we try to get to those as well. So next month will be fun, and we're going to have 2 of our nurse colleagues join us for that as well. One of them is from Kenya. He's a good friend of mine. He works in our ICU, but he goes back and forth.
Oh, anyone I know?
His name is Eddie Owino. I don't know.
I know,
Owino.
doesn't ring a bell.
Yeah.
Okay,
As
possibly.
soon as I met him, we became fast friends, and we've already been working on projects together. And yeah, he's great. Yeah.
Excellent.
Okay, let's get started. Let's see. Wonderful. Okay, welcome everyone. This is session 5 of the Foundations in Critical Care webinar series. Today we're talking about mechanical ventilation for ARDS, asthma, and COPD. Dr. Andrea Comiskey is the co-chair of this session with me, and we are super excited to welcome all of our esteemed international panelists. Dr. Tom Weiser is a clinical professor of surgery at Stanford Medicine and Program Director of SAVE at Welcome Leap. Dr. Freddie Ariza is anesthesiologist for major trauma and surgery at Fundación Valle de Lili in Colombia, and he's also a founder and leader of the Patient Blood Management course for the World Federation of Societies of Anesthesiologists. Dr. Wangari Sika is a professor at Aga Khan University in Kenya. She's experienced at working in higher education and healthcare industries and has a Doctor of Philosophy in Evidence-Based Healthcare from the University of Oxford. Dr. Michael Chen is a colleague at Stanford. He's an assistant professor of anesthesia and critical care medicine with expertise in liver transplant anesthesia and point of care ultrasound, and is our current director of ICUs. Dr. Rebecca Walker is an associate professor of emergency medicine at Stanford University and the director of postgraduate fellowships, and is also a faculty fellow of the Center for Innovation in Global Health. Dr. Javier Lorenzo is also at Stanford University, an anesthesiologist and critical care medicine associate professor, and is also the chief of staff at Stanford University. Dr. Andrea Komisky is emergency medicine and is completing her critical care medicine fellowship at Stanford and is the co-director of this webinar series, as I mentioned. We want to just do some quick housekeeping. This is a place of learning and also of respect. We want to build community. So if you disagree with something that someone says, please do so kindly and with respect. We do have the question and answer function at the bottom of the screen, so please use that to ask questions and introduce yourself in the chat box. We do encourage you to turn on your camera and video. We'd like to build community and put your face in the room. This session is being recorded and also live streamed on YouTube. There is closed captioning available. This should be seen at the bottom of your screen. It might help with those for whom English is a second language. And also, I just want everyone to know that all of the slides and materials and notes are already up and available on the Learning Resource Center. You can follow this QR code to get to the LRC, and you can download those slides and notes from this session. And lastly, we do have continuing medical education or CPD credits available through Stanford. If you registered for this session, you will automatically receive an email with instructions. You follow those instructions to get your CPD credit and certificate. We'd like to thank the Department of Anesthesiology, Perioperative, and Pain Medicine for sponsoring the CME credit for this webinar series. And with that, I would like to turn it over to my colleague, Dr. Andrea Komisky.
Hello again, and welcome to the 5th part of our series. We're very happy to have everyone here and in such a collaborative environment. For today's lecture, we're going to be reviewing mechanical ventilation in regards to ARDS, asthma, and COPD. And after this discussion, we are hoping that all the learners should be able to diagnose ARDS, asthma, and COPD, understand the pathophysiology of ARDS, asthma, and COPD, know the treatment options for these pathophysiologies, and employ appropriate medical ventilation strategies for each diagnosis. We highly recommend that the respiratory care pocket card shown here. So please take a moment quickly to scan the QR code that's at the corner and download your own copy for your own use. Although we will not go through every part of this reference, the information contained is very valuable to use at the bedside when making clinical decisions regarding ventilating patients. The pocket reference has 2 pages. The first page discusses predominantly oxygen therapy, respiratory mechanics, and modes of mechanical ventilation. And page 2 of the pocket reference that you'll see here contains useful information regarding setup of your respiratory care devices, lung protective ventilation, adjunctive therapies such as paralysis, proning positions, and troubleshooting ventilators and management of ventilator settings. And we would like to thank our friends at the opencriticalcare.org for making this amazing resource for us and many others to use for free. And so to start it all off, we're going to be covering mechanical ventilation for ARDS.
Thank you, Andrea. Our first topic will be ARDS, acute respiratory distress syndrome. This is a sudden and rapidly progressing form of respiratory failure. The term acute highlights its abrupt onset and rapid clinical deterioration. It is characterized by severe dyspnea, tachypnea, and hypoxia due to a non-cardiogenic pulmonary edema. ARDS develops in approximately 10 to 15% of ICU admissions and in 20% of mechanically ventilated patients. Among those with ARDS, nearly 80% require mechanical ventilation. ARDS is a syndrome resulting from various causes that lead to similar pathophysiology and treatment strategies. It can arise from direct lung injuries, for example, pneumonia, aspiration, inhalation injury, pulmonary contusions, or indirect injuries, for example, sepsis, pancreatitis, trali, medications, or any toxin. The hallmark pathology feature is diffuse alveolar damage, resulting in hypoxemia.
So in alignment with our other sessions, we're going to make this a case-based discussion. And today we're going to be discussing our patient seen here, and his name is Brian. Brian is a 32-year-old gentleman with a history of heavy alcohol use. He presents with acute pancreatitis, for which he has received intravenous fluids and pain control, and he is currently nil per os, or nothing by mouth. 12 hours into his hospital admission, he begins to have increasing oxygen requirement with tachypnea. He's placed on a non-rebreather oxygen mask at 15 liters per minute due to hypoxemia. And 2 hours later, the team that's taking care of him, which is you, decides to intubate Brian because his SpO2 decreases to 88% despite the high flow oxygen therapy. His first ABG reveals a PaO2 to FiO2 ratio, or a P to F ratio, of 97. And his chest x-ray shows bilateral infiltrates and diffuse edema.
So let's talk about the pathophysiology of ARDS. What is it? ARDS results from lung injury and diffuse alveolar damage that then leads to vascular permeability, which allows protein-rich edematous fluid to fill both the alveoli and the interstitial space. This leads to impaired gas exchange and hypoxia over time. And over time, the parenchymal damage can also lead to hyaline membrane formation, disordered healing, and lung fibrosis. And the injury can result in long-term damage if severe or untreated. Although hypoxemia is the hallmark of ARDS, there are other challenges to ventilating these patients. The fluid-filled alveoli make the lungs of ARDS patients less compliant and at higher risk for barotrauma, which is the variations in pressure across the lung due to mechanical ventilation. Additionally, atelectasis or overstretching of alveoli can lead to further inflammation of lung tissue. High levels of FiO2 can lead to oxygen toxicity, generation of free oxygen radicals, and cellular damage and tissue death within the lungs. As ventilator settings are adjusted to improve oxygenation, hypercarbia may occur, which can lead to acidosis and cardiovascular compromise. These potential complications must be weighed and mitigated during mechanical ventilation for ARDS. The definition of ARDS has changed over time. It was first published in 1994 and was then revised in 2012 and known as the Berlin definition of ARDS. You can see the definitions here. First, the onset of symptoms of ARDS must be acute. The bilateral infiltrates seen on chest imaging are diffuse, and they cannot be due to lobar collapse, pulmonary nodules, lung collapse, or pleural effusions. Respiratory failure cannot be due to some other non-pulmonary source, in particular cardiogenic failure or fluid overload. And there must be an impairment of oxygenation as defined by a PaO2 to FiO2 ratio, known as the P to F ratio. The clinical definition of ARDS was recently updated in a consensus document in 2024 to include both intubated and non-intubated patients, and also to allow diagnosis of ARDS in resource-limited and resource-variable settings. The committee made 4 main recommendations. First, to include high-flow nasal oxygen with a minimum flow rate of equal to or greater than 30 liters per minute, so not just intubated patients. Second, to use PaO2 to FiO2 of less than 300 millimeters of mercury, or oxygen saturation as measured by pulse oximetry. So instead of a PaO2, an SpO2 to FiO2, if the oxygen saturation as measured by pulse oximeter is less than 97% to help identify hypoxemia. 3, it retains bilateral opacities for imaging criteria, but it also adds ultrasound as an imaging modality, especially in resource-limited areas. And finally, in resource-limited settings, it does not require positive end expiratory pressure or PEEP, an oxygen flow rate, or specific respiratory support devices. To read more about these new global definitions, you can follow the QR code to the original article.
So how do you diagnose ARDS if you don't have arterial blood gas analysis and therefore can't do a PO2 FiO2 ratio?
So at this point, we encourage our participants, our audience, to answer this question in the chat box. How would you diagnose ARDS without arterial blood gases?
Excellent questions. Excellent response.
Thank you very much for those who responded. So several years ago in Rwanda, Riviello et al. Came up with what has been called the Kigali modification of the ARDS definition. And essentially what she allowed us to do for those who work in low resource settings is be able to identify ARDS based on oxygen saturations by pulse oximetry and FiO2, such that if you divided your SATs by FiO2 as a fraction of 1 and came up with a number of 315 or less, that would be defined as ARDS. It also allowed us to define ARDS even in patients who didn't have PEEP through a ventilator or high-flow nasal cannula of 30 liters per minute or more. And the third change was allowing us to be able to say the bilateral infiltrates haven't been looked at or examined further by CT scan or chest X-ray, therefore using ultrasound, lung ultrasound, whose use has increased in low resource settings. And of course, the caveat here is that everything else remains true, that from a timing perspective, and that you've essentially ruled out a cardiac cause of the infiltrates objectively by echo or subjectively.
I think it's important to realize that the Kigali modification, the definition of ARDS, came out long before the most current definition and guidelines that were described by Dr. Weiser. So it was really this Kigali modification that informed the new definition of ARDS. So thanks to our partners in Rwanda. So go ahead. Sorry.
Oh, sorry. So this slide is a reminder of what the FiO2 is delivered when using various oxygen therapy devices. For example, a non-rebreather, as our patient is using at 15 liters per minute, is already delivering 90% FiO2. And so if you look at that, his SpO2 is 88% as previously described, and therefore his SpO2 to FiO2 ratio is 97. So assuming all the other criteria for the Kigali definition have been met for our patient, he does meet the criteria of severe ARDS. So next I'm going to allow for approximately 1 minute for everyone to answer, but what ventilator parameters would you set for this 70-kilogram gentleman? And look at the mode, tidal volume, respiratory rate, FiO2, your PEEP, and even your IDE ratio. So we can give you a moment to answer in the chat box.
So many of you are describing the parameters, but we would like to know what values you would set. So if you have a tidal volume, what tidal volume would you set for this young man? What respiratory rate would you set? What FiO2 would you set? There you go. Some good values coming in now. Put your answers in the chat. Those are all good answers. Dr. Comiskey, do you want to talk a little bit more about this?
Sure. So remember, we will refer back to our respiratory pocket card that was discussed in the beginning, and it has all the information that you would need to set the initial ventilator settings, while also understanding that this is a dynamic process. So adjusting your settings as you get more information back and accordance to what the patient looks like as well is always very important. But all patients should undergo lung protective ventilation, especially patients with ARDS. There are several goals for mechanical ventilation in acute respiratory distress syndrome, including the parameters for tidal volume, your PEEP, your FiO2, and pH. And additionally, we will discuss the fluid management and driving pressure for these patients. But it's important to make sure that if you set an initial value, to go back, reevaluate, and make changes as you see fit in accordance to their clinical picture and what their trajectory clinically looks like.
In 2000, the ARDS network trial compared lower tidal volumes at 6 cc's per kilogram of ideal weight to traditional tidal volumes, which are historically 12 cc's per kilogram of ideal weight. This trial found that mortality improved with lower tidal volumes. It also found that ventilator-free days were higher. So lower tidal volumes are now universally applied to most mechanically ventilated patients, ranging from 4 to 8 cc's per kilo of predicted body weight. This is a key component of what we call lung protective ventilation.
Dr. Lorenzo, can I ask you, with a range from 4 to 8 milliliters per kilogram of ideal body weight, where do you usually start? Do you start at 4, 5, 6, 7, or 8?
Yeah, I usually start at 6 cc's per kilogram, and then I see where my ventilator settings end up, and then I titrate either up or down. I don't like to go much higher than 8 cc's per kilogram. There is a suggestion that there's a dose effect, so the lower the tidal volume, the lower the driving pressure, the lower the plateau, more of a benefit, but I start at 6 cc's per kilogram, and then I look at my other parameters.
I start at 6 as well. Does any of the other panelists start anywhere else when they decide on a tidal volume?
Absolutely the same as you.
Okay, nice.
Yeah, same here.
Another key parameter of the ARDS network trial was keeping the plateau pressure less than 30 centimeters of water. So the plateau pressure is usually less than the peak inspiratory pressure, and you can see it here on this flow diagram as P plat. The plateau pressure is more difficult to measure, particularly if the patient is breathing spontaneously. And the way we measure this on the ventilator is that we do an inspiratory hold at the end of expiration. This way, we can get a good or close representation of that alveolar pressure by measuring the plateau pressure. As tidal volumes are decreased in lung protective ventilation, respiratory rates are limited by breath stacking, you will notice that carbon dioxide levels inevitably will rise. This hypercapnia leads to a respiratory acidosis with a lower pH value. Although the exact pH values at which complications occurred is not known, most clinicians try to keep the pH between 7.30 and 7.45 to avoid the complications of acidosis or alkalosis. You can adjust the respiratory rate accordingly to keep the pH in a range. Although I would note that the ARDSNet trial did even tolerate lower pH values as low as 7.25. The goal of adding PEEP in ARDS is alveolar recruitment and the prevention of atelectasis for improved oxygenation. Adding PEEP can allow for decreased levels of supplemental oxygen and therefore decreases the risk of oxygen toxicity. Oxygen toxicity is thought to occur at levels of FiO2 over 55 or 60% for more than a few hours. So PEEP and FiO2 are titrated to a goal of PaO2 of 55 to 88 millimeters of mercury, or a SAT greater than 88% on your pulse oximetry. Higher PEEP levels may improve oxygenation and reduce ventilator-induced lung injury, but may also cause circulatory depression and lung injury from overdistension. So the PEEP must be individualized for each patient.
So I can already anticipate some questions around this. So from the panelists, when do you decide to use the lower PEEP table versus the higher PEEP table?
For patients who are in severe shock, so if I'm managing shock at the same time that I'm managing respiratory failure, I may not decide to use the higher PEEP because it could worsen your shock. I also try to use the higher PEEP on patients who are morbidly obese or patients in which the plateau pressures may not always represent alveolar pressure. So the morbidly obese, I try the higher PEEP, and patients in shock, I try the lower PEEP.
Dr. Lorenzo, do you mind taking our learning one step further and describe how high PEEP can worsen shock?
Certainly. So higher PEEP increases your intrathoracic pressure, which in turn will decrease your venous return to your heart. So cardiac output as a function of your heart rate times your stroke volume. That stroke volume is dependent on the venous return that returns back to your heart, to the right side of the heart. So the higher the PEEP, the more decrement to the cardiac output. And that's how it can worsen shock.
Wonderful. Thank you so much.
Can I step in, Andrea? And I would say that as a surgeon, I tend typically to start with a higher PEEP. I agree with Javier that when you have patients who are in florid shock, I'm a little bit nervous about that. Most of our patients actually tend to be fairly well fluid resuscitated on the surgical side. And so we will typically start with a higher PEEP and then go down from there. That's just a practice that I tend to gravitate towards.
Yeah, that's a good input and feedback. Thank you, Dr. Weiser. I think there's questions in the chat also about how do you individualize PEEP for different patients, and the points that you're making and the points that Dr. Lorenzo are making are all valid. Surgical patients are oftentimes very, very different from a sick medical patient. And so we definitely have different considerations for different patients. So thinking about whether the patient is volume resuscitated, thinking about whether the patient is obese, thinking about whether or not we're also managing shock are all considerations for where we would start with our PEEP. The good thing is once we set a PEEP, we can then titrate it up or titrate it down depending on the patient's needs, on their gas exchange and their hemodynamic status. So there's no one right answer. So it's one of those somewhat frustrating things is that there's no one right answer, and you actually have to take each individual patient into consideration, and then oftentimes have to make adjustments.
Yeah, can I jump in one more thing? Is you really have two options when you have patients who are profoundly hypoxic. You increase the FiO2 or you increase the PEEP. And so when you have somebody who's at the 80-100% FiO2, you really don't have many other options if they're still profoundly hypoxemic. So sometimes you're just kind of in a bind. But those are really the only two parameters you can titrate when you have somebody who is profoundly hypoxemic.
Yeah, true. Although we will talk about prone positioning in a bit. So it's another thing we can do for hypoxemia. But you're right.
All right. In ARDS, the alveoli and interstitium become fluid fill due to the inflammation and vascular permeability. This fluid contributes to hypoxemia and limits the fusion of oxygen across the alveoli and into the capillaries. There is some evidence that a conservative fluid strategy can decrease the number of days of mechanical ventilation. So as long as hemodynamics are stable and perfusion is adequate and organ perfusion is not compromised, most clinicians advocate for conservative fluid strategies in ARDS. So that means keeping the lungs and the patient as dry as possible. Some evidence also suggests a driving pressure may be better target than tidal volume, as it appears to be more reflective of the potential to induce ventilator-induced lung injury, particularly in patients with moderately severe to severe ARDS, so those with a PF ratio less than 150. We calculate driving pressure by subtracting PEEP from our plateau pressure. So again, that's plateau pressure minus the applied positive and expiratory pressure, PEEP. Providers should be able to determine the plateau pressure as measured on the ventilator using an inspiratory hold technique and may be able to identify the amount of applied PEEP. The goal is to keep driving pressure less than 15 to 20 centimeters of water when possible. I see some great questions on the chat. I don't know if you want to address some of those questions. I personally start with a PEEP of 5. I may start a little higher on patients who are more morbidly obese, and then I take a look at the compliance, take a look at the driving pressure, and then take a look where my plateau pressure is is finishing. So if my plateau pressure is less than 30 and my driving pressure is less than 15, I'm meeting some of those lung protective goals. All right.
Yeah. And as Dr. Lorenzo said, some of these patients just continue to get worse and kind of have refractory or even, just more severe ARDS. And we define that as a P to F ratio of under 100. So when you're taking care of those patients and they're kind of continuing to worsen despite optimal treatment and your vent settings that are a dynamic process, right? We've talked a lot about kind of responding to how the patient is doing and tweaking the mechanical ventilation. But there's a couple of things that we're considering now as adjunctive therapies to improve oxygenations. And I know I saw a question in the chat already about proning, and that is something that we are using. So these QR codes are linked to the direct articles describing the science behind this prone positioning. The study that had the best outcome for prone positioning that I saw was out of Spain and France. And importantly, that hospital had already been using prone positioning. So, they were used to doing it. And it is kind of a little bit hard to do mechanically with just taking care of patients in a prone position. So there's a learning curve there, just even the mechanics of it. Neuromuscular blockers are being used now, particularly in patients that suffer from dyssynchrony from mechanical ventilation. The PROSEVA trial is the first one that we have linked here, describing the prone positioning, which decreased the 28-day and 90-day mortality rate. So this is attempted in patients with severe ARDS, and they're getting worse despite these lung protective ventilation in a supine position. And it's been studied to be started within 36 hours of a diagnosis of ARDS. And several meta-analyses have kind of found similar findings, although there's a lot of science still being done. There's a lot of research still being done about that. Paralysis, there's mixed evidence, and so I'll show you an update in a minute that kind of shows where that is on the guidelines now. It's kind of patient specific whether that we think that will be helpful, but it is recommended in some cases. And then high-resourced facilities are considering and sometimes using ECMO, although that mortality improvement for ARDS has not been demonstrated to date. We do use it for other reasons successfully. And the next article so if you want to use those QR codes and kind of read more detail, but this in 2024, you can do the next slide.
I want to make one point about these three interventions, and that is that if you are going to do prone positioning, if you are going to give neuromuscular blockers, and if you are considering specifically veno-venous or VV ECMO, all of these interventions should take place early in the course of ARDS. So you want to initiate these things very early in the course instead of waiting late in the course, because especially with neuromuscular blockers, they can actually have worse outcomes if you give them greater than 14 days afterwards.
Thanks for that. Yes, so in 2024, the American Thoracic Society provided new updates to some of these previously published clinical practice guidelines for management of patients with ARDS. And it incorporated this new evidence and addressed the use of corticosteroids, the veno-venous ECMO, the neuromuscular blocking agents, and PEEP. And it kind of provides evidence-based recommendations for the management of ARDS. And this is the QR code to that article. But in summary, so the bottom of that graph is green, so strong recommendations for, as Andrea talked about, the lung protective ventilation. So you don't want to stretch those alveoli that Dr. Weiser kind of described, how that can cause damage. And recommendations, there are conditional recommendations for high PEEP, and there are strong recommendations for prone positioning, especially in certain patients. And then steroids, and then at the kind of more the yellow area is ECMO, neuromuscular blockade, that is a little bit more still in the conditional to certain patients, and recommending against the high frequency ventilation and the prolonged recruitment maneuvers. So as we know now, kind of that causes a lot of lung damage and more lung damage.
So congratulations, everybody. Brian has recovered from ARDS due to your excellent management and thoughtful, ongoing clinical processes with him. For him, he did receive some lung protective ventilation. You made sure that he was euvolemic. You provided early prone positioning, and you also gave corticosteroids. You provided adequate PEEP for him and judicious sedation management to make sure he tolerated all of these maneuvers, as well as timely ventilator weaning. And he has very, very grateful for all of the things that you provided him. So moving to our next mechanical ventilation strategy, we're going to focus on mechanical ventilation in asthma. So now we have Brian back, and he is 33 years old. He is 1 year after his pancreatitis and ARDS. He has stopped drinking and started smoking cigarettes instead. He lives next to a factory that contributes to air pollution, and he has recently been diagnosed with having reactive airway disease. He uses a rescue inhaler about 1 time per week. Sorry. And he presents today with severe asthma attack and presents to the emergency department. So next, Dr. Chen is going to walk us through the definition of asthma.
So asthma is clinically diagnosed and is readily recognized by its classic presentation with the 3 main cardinal symptoms of cough, shortness of breath, and wheezing, brought on by characteristic triggers that can be relieved by bronchodilating medications. It is difficult to provide a comprehensive definition, as asthma is very similar to multiple overlying conditions such as COPD and GERD. In the absence of an actual biomarker for asthma, again, it is up to the clinician to use their history and physical examination skills to help distinguish. Asthma is also most commonly associated with children, but can progress into adulthood, especially for patients with atopic symptoms like eczema or allergies. So the pathophysiology of asthma is very complex and not fully understood, but it is agreed upon that it is influenced by both genetic and environmental factors and exposures, such as cigarette smoke, allergens, and airborne, such as a cold, dry air. Some medications like aspirin and beta blockers can also trigger asthma. Typically, what happens in asthma is when normal airway is exposed to an irritant or allergen, causes a smooth muscle sort of bronchial hypersensitivity and airway inflammation, as well as profound mucus production and plugging of the airway. This causes difficulty for patients to exhale fully and is very characteristic for an asthma exacerbation. An asthma attack, like I mentioned, is exposure to various allergens and then mediated by an IgE antibody activation, which activates your mast cells and causes degranulation, resulting in the production of various inflammatory markers such as histamines, leukotrienes, and prostaglandins. These inflammatory markers then cause further bronchoconstriction and tightening of the smooth muscle cells, as well as additional inflammatory reaction to asthma. Over a chronic period of time, you can develop a chronic asthma characterized by breakdown of the endothelial cells, as well as fibroblast proliferation.
So the management of an acute exacerbation of asthma is outlined in this table here. This table is from Up to Date. For the sake of time, we won't go through everything, but the standard treatments focus on bronchodilation and supportive care. So typically this includes inhaled beta-2 agonists such as albuterol or salbutamol, oxygen therapy with a goal for SpO2 greater than 92%. This can be given by nasal cannula, by masks. It can be given by non-rebreathers or high-flow oxygen therapy, but that depends on what the patient's needs are. These patients should have good IV access for fluids as they get dehydrated due to their rapid respiratory rate and tachypnea. But we want to, again, avoid aggressive fluids and pulmonary edema, which will make oxygenation more difficult. Patients are also given inhaled anticholinergics. This is ipratropium bromide, or what we would call Atrovent. Systemic glucocorticoids, namely methylprednisolone, are also given for impending respiratory failure. You can use hydrocortisone, dexamethasone, and prednisone in less severe cases. Additionally, we often give magnesium sulfate intravenously, which can help relax the smooth muscles, especially in life-threatening cases of asthma. It's important for clinicians to recognize the danger signs in asthma exacerbations and recognize early making the decision to intubate. So that's a clinical decision, and it's when you are concerned for life-threatening asthma exacerbation. So patients with prolonged asthma exacerbation become too tired. They're unable to compensate. They become very fatigued. And they're actually at that point unable to maintain their gas exchange. If you have access to arterial blood gases, you will notice that when patients are tachypnic and breathing quickly, that their carbon dioxide levels will go down because of the fast respiratory rate. Once that carbon dioxide level starts to normalize, that's actually an ominous sign for respiratory fatigue. So these patients may have difficulty speaking. They also may have a depressed mental status, severe fatigue, and again, that rising carbon dioxide or carbon dioxide retention. That leads to the respiratory acidosis. Severe hypoxemia may also ensue. So these are life-threatening signs and will influence your decision to intubate and ventilate. When you do make that decision, it's important for the patient to get intubated quickly. So you might want to use a rapid sequence induction, and you might want to have the most experienced airway expert perform that intubation. And that's really to avoid laryngospasm and further bronchospasm and make sure the airway is secured quickly. You can choose medications that optimize the patient's physiology and optimize intubating conditions. Some may consider things like ketamine, etomidate, or propofol, and a quick-acting neuromuscular blockade such as rocuronium or succinylcholine. If possible, a larger endotracheal tube size will decrease the airway resistance, allowing the breaths to go in and out more easily. A volume mode is usually chosen on the ventilator because airway pressures in asthma are high. If you have a pressure mode, the pressures may be too high and you may get too small of a tidal volume. So typically the mode of ventilation is a volume mode. Respiratory rate should be adequate to ensure that there's good elimination of carbon dioxide and that you have a good acid-base balance. But it should also allow for adequate inspiratory and expiratory times. Tidal volume should be normal and lung protective. This decreases the risk of barotrauma. So again, we're going to talk about our tidal volumes that are 4 to 8 milliliters per kilogram ideal body weight. You can decrease the inspiratory time on the ventilator and allow a prolonged expiratory time in these patients, especially those with severe airflow obstruction. And this may be somewhere on the order of 60 to 75 liters per minute. 75 liters per minute is probably the upper limit of that flow. Allow for increased expiratory time by adjusting the I/E ratio. You can have extrinsic positive inspiratory pressure, meaning you apply PEEP, but it should be less than 80% of the intrinsic or auto PEEP. The flow trigger should also be set low enough so that the ventilator can fully support the patient's initiated breaths. And pressure triggers should not really be used for these patients.
So what is a fatal complication related to mechanical ventilation in asthma patients? I'll give you some time to think about this and answer in the chat. So good. I'm seeing many answers of pneumothorax and barotrauma, all of these which are along the lines of what's called dynamic hyperinflation, where you cause breath stacking or auto PEEP. So dynamic hyperinflation is when occurs when the lungs don't fully empty during exhalation, leading to dangerous breath stacking on the ventilator. So you can see on the top right, you have normal lungs where the tidal volumes return back to FRC, or the functional residual capacity, with exhalation, as long as there's enough time to exhale and that there's no airway obstruction, such as in asthma. However, in a severe asthma attack, the tidal volumes do not return to FRC, and with each successive breath, you have an increase in your total lung volumes. And this results in hyperinflation, which can decrease venous return and cause a decrease in blood pressure and hemodynamic instability. If this occurs, it is recommended to disconnect the patient from the ventilator to allow a prolonged expiratory period so that the tidal volume returns back to FRC. And so this is one of the edge cases where it's important to consider that in a patient with respiratory distress and hemodynamic instability, for which you think that there is auto PEEP or breath stacking, to disconnect the patient from the ventilator briefly before putting them back on the ventilator with an adjusted ITE ratio with a longer expiratory period.
So there's a lot of, I see like three probably main answers in the chat, Dr. Chen. One is barotrauma, one is pneumothorax, and the other is hemodynamic compromise. Which do you think is the most dreaded or fatal complication related to these patients?
I think pneumothorax is very dreaded because, it is sort of the result of barotrauma and prolonged hyperinflation and increased peak pressures within the patient. And so to avoid that and recognize this early is of utmost importance.
Yeah. I would also argue that the cardiovascular collapse due to high levels of auto PEEP and high intrathoracic pressures kind of goes back to what Dr. Lorenzo was describing earlier, where you have high intrathoracic pressures, which can decrease your venous return, leading to that cardiovascular collapse. So I think those two are probably the most dreaded and deadly. The barotrauma would have a long-term complications for patients, but the pneumothorax and the cardiovascular collapse are most likely to kill the patient quickly.
Just to piggyback off that, we actually had a patient the other day that we intubated for obstructive airway disease and ended up getting a pneumothorax and turned into tension pneumothorax very quickly. Thankfully, it was recognized early and was managed appropriately, but certainly something to keep an eye on. So that brings us to the next ventilator, mechanical ventilation management for COPD or emphysema, so obstructive airway disease. And now we're circling back to Brian, our patient. However, now he is 73 years old and he continued smoking and now has a 55 pack year history of smoking. He has developed emphysema through his pulmonologist who has seen him. He was admitted to the hospital 4 days ago with a COPD exacerbation that has been requiring non-invasive positive pressure ventilation, so CPAP versus BiPAP. And he has been receiving antibiotics and steroids, but has been clinically worsening.
Smoking or some other inhalational toxins lead to a chronic bronchitis and inflammatory damage to the airways and alveoli. The result is emphysema, as emphysema destroys the walls of the alveoli of the lungs, resulting in a loss of surface area available for the exchange of oxygen and carbon dioxide during breathing. There are more ventilated areas and fewer perfused areas. This results in dead space because gas exchange is not occurring in areas that are ventilated but not perfused. The hallmark of emphysema and COPD is carbon dioxide retention, leading to compensated respiratory acidosis.
And so referring back to Brian, Clinically, Brian has shortness of breath and can only speak 1 to 2 word sentences at a time, telling you that he has severe respiratory distress. His breath sounds are distant, but diffuse wheezing is heard, and he is using his accessory muscles while trying to breathe. You also notice that his chest is oval shaped, so the anterior posterior diameter, so front to back, is less than the lateral diameter, so the width. In a barrel-shaped chest, the AP diameter is equal to or greater than the lateral diameter, and the ribs become more horizontal and dorsal kyphosis is present, so very hyperinflated. Other findings are a prominent sternum, so the middle bone, elevated clavicles, and a shortened neck. And a barrel-shaped chest is usually seen in advanced COPD, as you can see with the diagram shown here. Aging can also produce a barrel-shaped deformity of the chest without any lung disease, just something to note. But in our circumstances, he does, in fact, have emphysema.
Okay, so COPD exacerbations do require quick treatment to prevent further respiratory failure. It was noted that Brian was started on non-invasive positive pressure modalities such as CPAP, but was on that for several days and was continuing to worsen. In general, COPD exacerbations are treated with inhaled beta agonists, again, albuterol or salbutamol, and inhaled anticholinergics such as ipratropium bromide or Atrovent. IV steroids are again given, specifically methylprednisolone. Antibiotics are something that are given in COPD, but we did not mention that in asthma because a lot of times it's an infection that can cause the COPD exacerbation. So you should consider giving antibiotics in these patients. If you think a viral infection is suspected, then antiviral medications can also be considered.
So despite your treatment with respiratory support and non-invasive positive pressure, unfortunately, Brian continues to worsen. You note that he becomes cyanotic in his lips and his fingernails when you're examining him, and he demonstrates respiratory fatigue. So he's just tiring out despite all of the effort he's giving himself. And his mental status becomes depressed. His heart rate drops to 50 and his MAP is 60. And so we proceed.
Yeah, so we can see from that scenario now that Brian has several indications for intubation. The fact that he is developing respiratory fatigue, he's obtunded, he's becoming more and more acidotic if you have blood gas analysis available. And because he's obtunded, it becomes a high risk aspiration risk when he's on NIV. And he's also got hemodynamic instability. So such a patient, therefore, has met indications for intubation and should be rescued.
Due to airway collapse, COPD patients will have retention of carbon dioxide and are at risk of air trapping and barotrauma. The primary goal are to optimize gas exchange, decrease the patient's work of breathing, and avoid dynamic hyperinflation. Typically, a control mode is selected with a normal tidal volume of 6 to 8 cc's per kilogram of ideal body weight. And the respiratory rate should be normal but adjusted for pH to avoid severe respiratory acidosis. Due to the abnormally high physiologic dead space, patients with COPD will often have higher than expected minute ventilation requirements and increased carbon dioxide retention. PEEP should be applied and the oxygen goal should be 88 to 92% on pulse oximetry. A higher inspiratory flow of 60 to 80 cc's per minute will allow the mechanical breath to enter quickly and allow for longer exhalation time. The carbon dioxide goal should be the patient's baseline, not a normal value.
So due to your excellent care, Brian is now extubated 3 days later and is sent back home 5 days after that. And so he is very, very grateful and thank you for your wonderful management of his COPD. So overall, thank you everybody for taking care of Brian in the last, 40, 50 years of his life, and he very much appreciates your help. And thank you for joining us today. We will allow for some time of questions, or if we want to acknowledge some questions in the chat.
Yeah, so we actually, I impressed upon the panelists that we usually run out of time. So we actually finished a bit early and we have some time, which is fantastic. So I would love to engage the panelists in a little bit more discussion about these mechanical ventilation strategies. So there's lots of kind of been following the questions in the chat box, but I think some of the ones that we should maybe just pull out are the mechanical ventilation parameters themselves. So there's a lot of questions about using a volume mode versus a pressure mode. So I'd like to hear from the panelists on why you choose one or the other, and specifically, would you choose a volume mode or a pressure mode in ARDS? In asthma or in COPD. So maybe I'll start with Dr. Lorenzo.
I'll just answer for ARDS. My preference is to start with a volume control. This way, I really can manage ventilation very closely. Keep in mind, either one would work. You just have to kind of monitor the patient and gas exchange very closely. If you pick up pressure control, as you diurese the patient, as you get the lungs a little bit more dry, your compliance will change, which means the ventilation will change, which is fine. You just have to monitor that. Pressure control will allow you to monitor the pressure and limit the pressure very tightly. Volume control will give you better control over the ventilation. So my preference is for volume control.
Yeah, just do any of the other panelists? Yeah, Freddie.
Yeah, I have one comment about Dr. Lorenzo recommendation. I think that as we are managing a critical condition where there are no solely ventilatory failure, we can find cardiac compromise and any other situation that we have to simultaneously treat. So it's important to know that no matter you consider an initial setting for your mechanical ventilation, you need to fit your parameters with the clinical condition and response of your patient, depending on the cardiopulmonary interactions that you have with those change. This is my recommendation, because many people thinks that this is a fit or a static parameter. This is dynamic and
Very dynamic. Yeah.
Can change along the day.
Yeah. Thank you for that. I think that's very important to recognize. No matter what we choose, we're probably going to have to make changes along the way. I want to again encourage all of the learners and participants to download that respiratory card, because it walks you through the parameters at which you can start, but also how you can change those parameters depending on different values. Dr. Weiser, you were going to say something, I believe.
No, I was just going to say exactly that and reiterate that these patients are very dynamic. And so having kind of a starting point is not going to be your likely end point. So once you start with your ventilation settings, you want to carefully watch that patient over time and start adjusting your strategy depending on how patients respond. So it's really important. I know there's a lot of questions about where do we start. The key is it's where you start. You'll end up in different places with different patients.
Again, that respiratory card, I think everyone should download it. It really is very helpful in making those decisions as the clinical picture changes. Let's talk a little bit about FiO2. I feel like we didn't spend a lot of time on that. We did mention that for the asthma patients, we would target an SpO2 greater than 92, and I think we mentioned for the COPD patients, we would target an SpO2 greater than 88. There's also a question in the Q&A about how often do we check arterial blood gases? So Dr. Sika, can you talk a little bit about your thoughts around where do you start with your FiO2 and how do you make changes to your FiO2? Do you use arterial blood gases every time, or do you use the SpO2, et cetera?
Thank you. I think there is no one size fits all, really, is there? So it really depends on the patient and whether they have pre-existing lung disease, for example, and that sort of guides where we start. As you've said, if they have, chronic lung disease, my targets will be lower for the saturations that we achieve, even in the context of ARDS. And it depends on, as you said, on many things. So I'll probably start high and come down generally. It's my preferred strategy as I watch the saturations. But also being very conscious in my response around blood gas to say that in this part of the world, it depends a lot on what resources you have available to you. So we do have colleagues who only have pulse oximetry to use as a guide for how well they're doing in terms of coming down on that oxygen FiO2. So where I work, I'm privileged that I work in a well-resourced facility, so we can do blood gases as often as we like, really. But in less resource centers, then you may find that you may have just maybe one gas or none and just be guided by saturations. Perhaps carbon dioxide is the harder one to then monitor. Pulse oximetry, I think, is easier because then if you don't have blood gas analysis, then you don't have EtCO2, assuming there's a correlation, then where do you go from there? So yeah, very long-winded answer to say it depends on so many things, depends on the patient and depends also on the center that you're working at least for us on this part of the continent.
I actually think it's an excellent answer. And I would add to that even if you are in a well-resourced institution, I still try to impress upon my trainees, my residents, my fellows, my medical students that just because you have arterial blood gas analysis doesn't mean you have to do it so often. And in fact, you can use the SpO2 to make changes, especially when we're talking about FiO2 and PEEP. You're absolutely correct about carbon dioxide sometimes being the harder one to manage. I think a lot of people have heard of Lifebox, the nonprofit organization that's been putting pulse oximeters in operating theaters around the world, and their newest project is actually on introducing capnography during surgeries. So that's I think another good methodology for keeping track of your end-tidal CO2. I'm gonna pick on Dr. Michael Chen to tell us a little bit about FiO2 considerations, what you think about when you have a patient with emphysema or COPD. What's your target SpO2? Where do you start with your FiO2, and why don't you shoot for 100% on your pulse oximeter?
Yeah, so I tend to typically target a SpO2 of 88 to 92% for our severe COPD exacerbations. Avoiding excessive FiO2 and hyperoxia can actually decrease the respiratory drive and worsen sort of the breath stacking and the ability to keep up in patients with it. In terms of for asthma also, I tend to sometimes more quickly jump to a pressure control sort of ventilation sort of setting for some of these patients, just because of the barotrauma and trying to overcome sort of the peak pressures with the pressure control flow modes, which kind of tapers off at the end of the cycle versus a square wave that you get with a volume control management to kind of help with some of these pathophysiologic states that are involving sort of higher sort of volumes and pressures on the ventilator.
Thank you. Yeah, that's interesting. The one thing you mentioned that I kind of want to have the panelists talk a little bit more about is you mentioned that if you have a higher FiO2, that it would decrease the respiratory drive in an emphysema patient. And I learned that also when I was a medical student, that the patients that are that have emphysema and COPD rely more on a low FiO2 for their oxygen drive. But in fact, it was Dr. Ann Weinecker, one of our colleagues at Stanford, that said, in fact, that's not really what's happening. What's really happening is when you introduce a high FiO2, you override what's called hypoxic vasoconstriction. So when you have portions of your lung that are not participating in gas exchange, the blood flow to those segments will constrict so that you can shunt the blood to areas that are participating in and gas exchange. And so when you give extra FiO2, what you're actually doing is reopening those places that were vasoconstricted. And so you're really affecting your VQ mismatch. So I find that is interesting what we are taught in medical school versus what we learn a bit later, and perhaps it's a little bit of both. But just wanted to introduce hypoxic pulmonary vasoconstriction as a concept. Let's see who else should we pick on today. So there's some questions about the pediatrics population, and I will confess that we have not talked a lot about pediatrics at all. Do any of the panelists have different considerations when they are ventilating pediatric patients with ARDS, pediatric patients with asthma? Maybe Dr. Walker, do you have different considerations for pediatric patients?
Yeah, I mean, I think I've had kind of the similar experience as Andrea of just having an asthmatic patient be intubated and then having barotrauma or tension pneumothorax. And so we are so careful about intubating pediatric asthma patients that we try, like someone in the chat had asked about ketamine or even like IV epinephrine, and sometimes we will try some of those things that the research is still kind of unclear. It's not always recommended, but it's so dangerous to have, they have such bad outcomes after being intubated that in order to try and avoid intubation, we will do kind of like a 1 mg per kg IV ketamine for like an hour and then decrease the dose for another hour and a half, just to attempt to avoid intubation. So it's kind of, and it's a dissociative, it's a bronchodilator. So there's a reason that pathophysiologically we think it might be working sometimes, but the research is unclear still. There have been studies that I think I put a meta-analysis in the chat from 2024 that still seemed unclear, but we do it.
Dr. Ariza or Dr. Sika, do you care for pediatric patients?
Yes.
Yes.
I think that the more important point in pediatrics is to keep in mind that protective ventilation is a concept proved and tested in pediatric population. So we can start with this objective to initiate mechanical ventilation with protective parameters. And I would like to remark on the possibility to initiate with inspiration expiration ratio of 1 to 2, because especially in asthma, because we need to listening the possibility to autopiff in these patients.
Yeah, and we can actually extend out that expiratory time, right? We can do 1 to 3 even. So that's an excellent point. Dr. Sika, what were your thoughts?
Yes, thank you. So with children generally, I was taught to always use pressure ventilation. And then you watch what tidal volume you achieve with that, aiming, of course, for the 6 to 8 per kilo. Bearing in mind, of course, that a lot of the pediatric endotracheal tubes will be uncuffed. So if you go for pressures above 20, then the likelihood of losing a lot of that tidal volume breath is increased. And so there has been a move, especially in treating things like bronchiolitis, for example, to then use cuffed endotracheal tubes, even in the pediatric population, so you're able to go to higher inspiratory pressures. But generally for children, it's a square wave pattern, pressure ventilation, and then you look at with that pressure, you are achieving the tidal volume of 6 to 8 per kilo. And I think it's important because if you think about, say, a 7 kg baby, 6 mils is 32 mils. If you set a tidal volume of 32 mils, a lot of it is lost in the circuitry and in the tubing, whereas a pressure mode is more likely to deliver what you want to deliver to the child ultimately. So that's the one difference for me. I never use volume ventilation in children, no.
Thank you so much. I'm so glad that you're on the panel. Have to confess I'm incredibly biased. I only take care of adult patients in my setting. So thank you so much for your expertise on that. I want to also transition now to a little bit more conversation around prone positioning. There's a question in the Q&A about if you have a patient in a setting that doesn't have mechanical ventilation and the patient is determined to have ARDS, are there other things that you can do? And the first thing that came to mind was prone positioning for that patient. Ultimately, if the patient is very sick, you want to transfer them to a higher level of care if possible. But I think it's important for us to talk a little bit about prone positioning. Dr. Lorenzo and I worked together during the COVID pandemic, and we did a lot of prone positioning. So, Dr. Lorenzo, do you mind sharing some of your thoughts and techniques about prone positioning? And before you do, I just want to mention one thing. There's a video on the Learning Resource Center about how you prone position. So for those of you who have not done prone positioning and are not sure what to consider for that, you can watch that video. And there's lots of videos online as well about prone positioning. But Dr. Lorenzo, when do you use prone positioning? How do you use it for how long and in which patients?
Great questions. I will also add that for those centers who don't have the support for mechanical ventilation, there is evidence that having the patient spontaneously prone themselves actually does help. We learned in the COVID pandemic that, self-proning and encouraging the patient to prone actually lower the risk of being intubated for respiratory failure. So even doing it on the awake patient, not intubated, there is some benefit. When we do it on patients who are intubated, you really want to have the right people in the room. So you want to have, at least a couple of nurses. You want to have a respiratory therapist. Initially in Stanford, we would have an anesthesiologist available, but actually we learned that the risk of losing an airway is actually really low. So you don't always have to have a patient, an anesthesiologist or somebody who can intubate, but having some awareness that procedure, the proning procedure is happening, is always appreciated. So in Stanford, we have like a weight limit. We have I think it was one nurse for every 50 pound or 30 kilos for a patient. So you want to make sure you have enough hands to prone a patient. Sometimes when the patients are not deeply sedated, you may have to deeply sedate a patient to prone just because the benefit of proning was shown for a 16-hour prone window. So that may not be a time that an awake patient may tolerate in the prone position. So you may need to deeply sedate. I always monitor the pressure points. The eyes should not have pressure. You want to make sure that you are moving the head with some frequency. We do it every 2 to 4 hours at Stanford. And similarly, when you go from prone to supine, you want to have enough people in the room to make that proning repositioning safe for the patient.
Wonderful. Thank you so much. Yeah. Any last minute thoughts about mechanical ventilation that are teaching points that you really try to share with your trainees or students? What are some of the main teaching points that you use, Dr. Comiskey?
I think the big things that we've stressed this a lot today is making sure to start with lung protective ventilation and then understanding that adjusting according to the clinical picture of the patient and their trajectory and being at bedside, looking at their ventilator, looking at the settings and their pressures and their volumes, and just making sure you're making adjustments that's both safe for the patient and to help you with your long-term goal of trying to get them better from ARDS, COPD, asthma, whatever your pathology is. So a ventilator is not something that you set and forget and walk away. It's something that you continue to manage throughout the day and the time course that you have the patient under your care, and trying to make sure that you're meeting all the clinical standards you're looking for in order to see improvement. And then adding adjuncts as well on top of that to try to optimize your clinical picture, such as steroids, antibiotics, proning if needed, and just having that discussion with the team and making sure everybody has an understanding of what the plan is going forward.
Dr. Sika, last minute thoughts?
I think for those who work in areas that don't have, great staffing, for example, one of the things I find very useful is to involve your nursing colleagues in critical care and setting very good alarm limits and leaving instructions for what you'd like them to do in the event that you're not on the unit because you've had to go away and there's no one else to come in. So what have you set as, especially if you, for example, set a pressure mode and you don't want the tidal volumes to change to either extreme because the compliance has changed in the course of the day. So what can the nurses do when you're not there? What can they titrate when you're not there for the sake of the patient and to keep them safe? So involving nursing staff and setting very good alarm limits, I have found in centers without staff have been quite helpful.
Yeah, I think that's very good. I call them if-then statements. So if this happens, then do this. If this happens, then do this. Yeah. Dr. Ariza, any last minute thoughts?
No, not really. Thank you for the invitation, Anna. It's an incredible session, and I think that we have covered the most important features for initiating a successful ventilation in these patients.
Thank you. Thank you. My last minute thoughts go to ventilator weaning. So I think it's really important for all of us to recognize not only how to support the patient fully, but also to recognize when the patient is starting to improve. And so I really feel that ventilator weaning is almost as important, if not more important than placing a patient on the ventilator. I see a lot of patients who are not weaned quickly enough, and then they develop pneumonia and septic shock and eventually perish because of that. So I think understanding that we make changes based on what the patient needs, and that includes going down sometimes on FiO2 or some of the support that we give. I have absolutely loved this session. I've loved that we had time for the question and answer at the end. I want to thank sincerely these great panelists, Dr. Walker, Dr. Weiser, Dr. Ariza, Lorenzo, Sika, Chen, and Komisky. Thank you so much for making this panel amazing and engaging. And we will see you next month. Next month, we are doing a frequently asked questions session. So we're taking all the questions that you have submitted when you register and lots of questions from the chat and Q&As for the first 5 sessions and really diving into those a little more thoroughly. So thank you everyone so much. Again, if you register, you will automatically receive an email that gives you instructions on how to complete an evaluation. So you will receive your certificate, you will receive your CPD points that way. Thank you so much.
Thank you. Bye.
Thank you. Bye-bye.
Bye, everyone.
Adios. You guys are so cute. See you.